not only in New York, I got involved in University of Tel Aviv. If you look at the column, the middle one, you see my name and my wife's name. We do charities, give to the University of Tel Aviv, and do research with them. Dr. Shapira, Shaki Shapira, is my good friend. And he's just reached 90 years old this year, but he's still teaching there part-time. Among various publications that I have, the latest one with Dr. Shapira, it's just accepted by the AJODO clinical. This journey is connected to the Elsevier, and I give the link to Charlie. So if you want a free download, you have until January 22nd to free download my article, and he will give it to you. Thank you.
How much is it after that?
You might have to translate it in Greek. So partners in dentistry and medicine, it's us. Although partner in Europe, MEM in Taiwan, now we're spraying to Tokyo, Japan. We just built a lab there. I have to disclose myself. I have an interest in the MEM company. As an investor, board of director, some decision making, and sometimes chief technical officer. So I try new brackets and wires, and pretty soon I'm gonna try the software from the Cleveliner. And the university, Cleveliner, and we are working together to get the best products available to all the providers. So I'm very glad that I'm invited to help organize today's seminars. How many of you are orthodontists? Can you raise your hands? Yeah, majority of you orthodontists. How many of you interact often with a surgeon for your surgical cases? Can you raise your hands? That's pretty impressive. So you will discuss the case, get the treatment plan, and discuss whether the patient needs one or two jaws, or how much of upper jaw can be moved, rotate, detail. You work with them like that. That's very good. The interaction and communications are very important to get a very successful result for the patients. This example is 22 years old Asian patient. He came to our clinic with 4 teeth missing. Right away, we figure he's a shopper. He will go around and shop around for his treatment. So he didn't continue after the first orthodontist ordered the extraction, and then he entered to our clinic. Now he's shopping for surgeons and orthodontists to take care of him. He's an anterior open bite, class 3, bimaxillary protrusion, crowding. You can tell without even measuring the angulations, and he is bimaxillary protruded. And long face. That's one of his chief complaints. My front face is very long, and he wants us to solve the problem, the issue. So these are the cephalometric measurements. All the red ones are out of range. I don't have time to go through, so you can take a picture and analyze yourself later on. So after we got the records, including CBCT and stone models, we sent it to the commercial lab. We don't have the in-house software facility. We have something in this building, but they usually work with surgeons. But usually we send it out. Oh, by the way, it costs about $3,000-4,000 for each patient, and usually paid by the insurance company. It's like a package deal to them. Because of the mild crossbite and mild class 3, some surgeons and orthodontists recommend that, let's just do one jaw surgery. You don't have enough problem to do two jaw. So plan A was one jaw surgery, maxillary advancement. So Lefort, one cut. This is a pre-op. And after the Lefort surgery, the maxilla is moved forward. And the mandible, it's auto-rotated to occlude with the maxilla. Right there. So this is before auto-rotation and after auto-rotation. And because of the short throat length, soft tissue and hard tissue, they have to do the genioplasty to increase the throat length, especially for the male patient, otherwise they're going to look feminine. And if you have a obese patient, even worse, they have a double chin, triple chin, and you do have to worry about those look, otherwise the patient's not going to be happy after that. So before and after comparison, there's really not much of a change. It's still bimaxillary protruded because we have no control of where the maxilla is. When you swing the mandible forward, the maxilla has to occlude over the mandible. Yeah. I'm going to skip a lot of these, so we don't have time to go over each. So this is a final occlusion. Okay. This is another heat map. Okay. I'm going to stay a little longer on this one. If you check the pre-op and plan on this, there's not much of a difference in a change in a maxillary occlusal plane angle. 1 degree, it's almost nothing. So the patient still have a high mandibular plane angle, high occlusal plane angle. The anterior face height is still long. So that's the prediction of the soft tissue with one jaw surgery. So usually the software engineer from the company, orthodontist and the surgeon, we have a conference call, Zoom, and discuss what's the possibility, how much of a movement you can make. After I saw the result, I said, we cannot accept this one jaw surgery. So can you do two jaw surgery? So the next day, he worked a few hours and came back to us. So this is a two jaw surgery. Okay. This is a pre-op position. This is the after the maxillary movement. So we use intermediate splint to position the osteomized maxilla by using the intact mandible to position the upper jaw. So that's called intermediate split. And this is after the mandible is cut, BSSO, bisagittal split surgery. The final split is made based on this. This is before and after. You see the marked change in occlusal plane angle. The 0.7 millimeter gap there, it doesn't represent the sagittal movement. The big gap is actually 7.4 millimeter. It's right there. The other measurement, it's a vertical gap, not the sagittal gap. So these are the measurements after 2 jaw surgery. Quite a big change, 6 degree change in this is pre-op and post-op, the measurements. Now we can say where the maxilla is going to be, not based on where the mandible is. Now we can manipulate all the movement sagittally, vertically, and angulation of the OP and MP angle. This is a comparison of 2 jaw and 1 jaw surgery. Notice that occlusal plane angle change 6 degree or more between these two. So that changed the height of the anterior face. That changed the position of the mandible, the angle of the border of the mandible. That also improved the retention. Because of the muscle attachment on the mandible, the masseter, the temporalis, all these muscle attachment are causing the relapse. If they pull it in the wrong direction that you want, then there'll be more relapse. So by doing 2 jaw surgery, cutting the mandible will minimize the relapse because you're changing the attachment angulation of the muscle and ligament. So keep that in mind. It is not just the look, not just the occlusion. We have to worry about the relapse, the muscle attachment, the soft tissues, and the hard tissue. This is the comparison. This is a post comparison of the soft tissue changes. Pre-op, 1 jaw surgery, and the 2 jaw surgery. So if you have any question, Dr. Ray Chen and I will be happy to answer after we finish the whole thing. We have to rush. The next one will take another 10 minutes or so. So if I can, it's old school versus digital age. Before the visual surgical planning software and it's available, we have to use our hands and eyes and to measure. This is the timeline of the surgical group that I got involved. Okay, in 85 to 95, it's IRPS, Drs. McCarthy, Dr. Cutting, Grayson, Dawn, Zeit, all these. Some of them are MD DDS, some of them are just MD plastic surgery. Now, McCarthy is a famous one that published 8 volumes of plastic surgery textbooks. 95 to 05, it's NYU Dental School, Bellevue Hospital, Lenox Hill. Dr. Super, Glickman, and Collins are the main force leading us in the surgical cases. And 2005 to now, it's NYU Dental School, Bellevue Hospital, NYU Langone, which is changed from NYU Medicine Center. So Langone is the owner of the Home Depot. If you notice, he donated $1 billion to the school, so all the medical students got free tuition. Because that $1 billion can generate enough money to support the whole medical school, which is about $100 billion a year. So the old school, I'm going to skip a lot of these basic stuff because you know this already. The difference between a normal pleasing face and an aesthetic asymmetric face may only be a matter of degree. These are all kinds of syndromes that can cause the asymmetry of the face. These are the classification of face of Monroe classification. Record taking, you got to take just a simple facial and lateral. You got to take water view, you got a 3/4 view. This is a comparison of normal patient and asymmetric patients record taking and cephalometric. So before the CBCT was available to the general use by the orthodontist, this is really pain in the, like shown in the picture. A lot of work, time consuming, a lot of guesswork, a lot of eyeballing, and the margin of error is huge. So let me go quickly, okay? This is a dawn of the 3D set. We work with the in-house software in Langone, combining lateral ceph and a PA ceph to come up with this wireframe, sort of very rough 3D picture, like that. That's before the CBCT and dolphins are available, all hand tracing and wireframe, and we use that to figure how we should move the segment of the osteomized bone. Rotation XYZ axis. You see, even though we're very primitive method of hand drawing, we still use the same landmarks that the software engineer using to move the segments. Upper incisor edge, lower incisor edge, right upper molar tips, stuff that we can see and trace reproducible landmarks. See? So construction of splint for one jaw surgery, it's quite simple. You just mount in a simple articulator and make a splint handmade. No 3D printer was available at that time. So everything is methacrylate, wireframe, and so this is for 3 reconstruction. There's need 3 splints, first, second, and the final splint. It's almost impossible to get a natural asymmetry skull, so I have to go get order. At that time, there's no eBay, so we have to buy one plastic skull and cut it and create asymmetry cases. And the articulator, we use a semi-adjustable articulator. Try to mimic the asymmetry. Faceable records, remember? Infraorbital rim, you point the index pin and you mount the upper cast. So in the articulator, we mount the upper cast first by using the faceball. Then we turn it upside down and we mount the the lower cast according to the impression that we took from the patient, while the patient's open like 2 millimeter, because that's the amount of the opening that we need in order to make this intermediate splint. So we mount this splint onto the maxilla and then mount the mandible accordingly. That's on your left side. On your right side, you cut the upside down and move it down according to the requirements from your measurement. Then the final splint, you make the final splint, turn it upside down. So now you got 2 splints. One is thick on one side and thin on the other side, and the other one is very uniform, thin. So there's example of peri-rhomboid syndrome. The surgeons are Joe McCarthy, who was the head of the IRPS, and Barry Grayson, it's my boss, orthodontist. Let me go quickly. 17-year-old. He's got a whole medical and dental history that require many times of surgery. Left, right, symmetry, exclusion. Pre-surgical orthodontist is about 1.5 years. Hand traced PSF. So these are the movement that we cut on the cast and we move according to these measurements. So this is a plan. LaForte 1, impact the right side, down fracture the left side, then fixate that with the intermediate splint. Mandible, differential advancement. So both sides need advancement, but the hypoplastic side need more advancement. After that, the patient still need orbital correction, genioplasty, auriculoplasty, and soft tissue augmentation. So, like I described before, we mount these casts in the articulator, hand mount, hand cut, construct the splints, and the surgery. You think that you're prepared and you're ready to go. But take a look at this. After you cut the maxilla, you lose all the reference point. How are you gonna? There's no index pin like your articulator. So you lost after maxilla is cut. In the old time, the surgeon eyeballed it. This looks pretty straight. This looks pretty, according to the nose and chin and the reproducible index. It's lost once maxilla is osteomized. So the 3 landmarks are tattooed on the patient's face, either tattoo, permanent tattoo, very small, or just Sharpie pen, nasium, menton, and reconstructed porion, which is the fake ear hole, external auditory meatus, to just mark it on the patient's head. And right after the maxillary surgery, you take x-rays and then make sure that all the splints are working right, all the positioning. So this is before and after. You notice the scar tissue on his left cheek. This scar is like a chicken or egg. Because of this scar, he become asymmetry, or because of asymmetry and there's a scar. By looking at the face without looking at the eyeball, the surgical correction is pretty successful. But if you look at with the eyes, there's not much of a difference. It's okay. It's okay. I just text them that we're going to be 15 minutes late. Okay. Again, cover the eyes. So this is a future surgical plan. Now the digital age. My colleague, Dr. Rachin, was working on this, and I'm going to let him come and continue with the presentation. It's a level 1 osteotomy. The right, it's inverted L osteotomy, which allow you to extend the ramus in really maximum extension. AICBG, it's anterior iliac crest bone graft. You harvest the bone from the iliac crest. Genioplasty. So I'm gonna, Dr. Rachin, please. Thank you.
Yeah, just what we do. Yeah. I don't need my notes. So I don't know.
You have 15 minutes.
Yeah.
Thank you.
All right, good afternoon. My name is Dr. Ray Chang. I'm a private practice oral maxillofacial surgeon down in downtown Manhattan. I want to thank Dr. Yan Lai for inviting me to give this presentation. So I trained here at NYU over a decade ago, and I had this presentation with Dr. Yan Lai that we had presented together back in 2016, 2014. We had 4 patients that we treated together that involved ramal reconstruction in patients with facial asymmetry. So that's what we're going to discuss. So I'm going to fly through this slide since we don't have that much time, but all of the cases require ramus reconstruction. Obviously, we know that the ramus gives us the vertical height of the lower face, so it's very, very important. These are some of the causes of facial asymmetry, either from congenital or acquired defects. Fixing patients with facial asymmetry obviously requires a multidisciplinary approach. The orthodontist is the most important member of the team, and then the oral surgeon has to basically plan out the orthognathic treatment, but at the end of the day, the occlusion is the most important, and the reconstruction team obviously may involve the plastic surgery team as well. But these are some of the reconstructive options. So distraction osteogenesis is obviously the gold standard for the pediatric population, but it does require 2 surgeries and wearing a distractor on the face. So today I'm going to focus on 2 procedures that we did mostly at NYU, which is the inverted L osteotomy with the anterior iliac crest bone graft, the bilateral sagittal slit osteotomy, and also the condylectomy and the costocondyle rib graft. So just in short, inverted L osteotomy was founded by Dr. Wasman, who was mostly for mandibular hypoplasia for patients with deficiencies in both the horizontal and vertical dimensions, for class 2 patients that look like this. The way that we perform the inverted L osteotomy, we use the transfacial risen approach, and this gave us really good ability to perform the L osteotomy and have rigid fixation with our fracture plates. There's minimal overlap, minimal relapse, because we would fixate bone, and there was also a very low risk of neurosensory injury. Now, as Dr. Yan Lai mentioned, virtual surgical planning had really revolutionized just orthognathic surgery treatment planning completely. Back in the day, I used to, just like what Dr. Yan Lai said, I would have to pour up the cast, make the splints, do the surgical planning just by hand, and that was, there was a lot of error to it. But now we use medical modeling at NYU, where we used to just send casts and the CAT scan, the medical grade CAT scan with the occlusal splint, and then we would go through the treatment planning with the medical modeling team. They would fabricate the splints for us and then provided us with very good accuracy. So case one, Dr. Lai showed very briefly. This patient also had Perry-Romberg syndrome. I'm not going to go over all the medical issues, but basically, this patient, he had been in orthodontic treatment for about 2 years. He has a class 1 occlusion, a couple missing premolars, but he has that very obvious occlusal cant. Our first phase of our treatment was to correct the maxillomandibular complex, just the bony aspect, and leave the soft tissue aspect for the plastic surgeons later on. So you can see on this pan that the right ramus is significantly shorter than the left. This is the lateral ceph. The surgery that we planned, as mentioned, was the Fort 1 osteotomy, a right-sided inverted L osteotomy with an anterior iliac crest bone graft, left sagittal split osteotomy, and a genioplasty. So this was his pre-op. Post-op, they actually fabricated some cutting guides for us. This was the interocclusal intermediate splint. So for this case, we did the maxilla first. This was the cutting guide for the L osteotomy, which was very, very helpful. The amount of vertical height we were able to plan out was about 6.5 millimeters. Horizontal, we wanted to advance his mandible about 9.2 millimeters. This was the VSP for his final, and these are some of the numbers that we wanted to achieve. So these pictures were from another patient, but similar case. So you could see that we had to downgraft the right maxilla, so we added some AICBG bone in there, as shown.
Okay, can you go back?
Oh, yeah.
That little rectangular piece of bone, it's in the old time, after we harvest the bone from iliac crest, look at it, we're gonna cut it, file it, cut it, fit it. Now, the company sent it to them, a plastic model that fits exactly there. So you harvest the bone, you just have to cut it according to that. And then you put it in the patient, it fits. So in the old time, the surgery is supposed to take 4 or 5 hours, it takes 6 hours, 7 hours. Everything is, you have to custom make during the operation. Now, because of the software available, and these engineers will ship it to you. They will all the pieces that necessary to graft on one side, it's there. So it's so easy. They got lazy. The Thank you.
No worries. So this is the image of the risen approach for the inverted L osteotomy. So we were able to place the cutting guide on. That was how much we were able to advance it with the AICBG. We put the 2 fracture plates on, and this was the immediate post-op pan. See that we were able to get very, very good bone-to-bone contact with the cutting guides and good vertical height. This was, I believe, 3 months after. This was his lateral ceph. And this was him, I want to say about 3 to 4 months after the procedure. Obviously, he still has his soft tissue defect, but his occlusal plane and his smile is much, much improved. He was still undergoing orthodontic treatment afterwards, but he still had his class 1 malocclusion. So second case very quickly was a patient with focal dermal hypoplasia, similar with facial asymmetry. Her right-sided ramus was significantly shorter. This was her composite 6. And so for her case, her chin is deviated to the right, obviously. For her, we actually decided to do the mandible first. We wanted to stage it because of her medical comorbidities, and this was her lateral ceph. So it was a right-sided inverted L osteotomy with an AICBG, left-sided sagittal split osteotomy and a genioplasty. So same as the last case, but without the Lefort 1 osteotomy. So that was her. This was what we planned. This was the cutting guide. And this was how much we wanted to advance her with the genioplasty. And so this was her post-op pan. We put a very large recon plate on, took a lot of bone from her AICBG, BSSO, SSO, genioplasty, and we just left the maxilla. This was her lateral ceph. This was, I believe, 6 months after. You can see that the bone really consolidated well. And for her, actually, the orthodontist was actually able to align her maxilla by extruding the right side of her posterior teeth, so we avoided having to do any more surgery for her. But we did actually end up taking out number 17, took out the SSO plate, and then put malar implants, maxillary implants in her instead to avoid more aggressive surgery. So this was her post-op. She has a lot more chin protrusion now. Her bite. Okay, so third case is a hemifacial microsomia case. This one I'm going to run through just because it's very similar to case number 1. But he was a Przansky type 2A. So this was him smiling. He didn't have ortho treatment yet because he still, he had decent occlusion. This was him before, but you see the obvious occlusive cant here, hypoplastic ear, and this time it was the left side that was hypoplastic. So we basically planned the same procedure, the surgery for him, but in this case we actually did the mandible first because we cared more about leveling his ramus, just getting his ramus done first, and then we leveled the maxilla, we matched the maxilla to it. That was our plan, those were the measurements. It was a big movement for him, a lot of vertical height. This was him again, same exact surgery, we did the AICBG, placed it in. We were very happy with his post-op. This was 6 months after. So if you look at his smiling picture, he already had the marginal mandibular weakness before the surgery, but his occlusion was leveled. We were very happy. Fourth case, again, I'm going to go through very quickly. I added this case because it included the condyle. So this patient, she was 21 when she came in, but 10 years prior she had a trauma to her right TM condyle, so she ended up with fibrous ankylosis, and with dental compensation. So her bite was not great, but she really just wanted to fix her facial asymmetry. So you can see that the fibrous ankylosis causing her right ramus to be severely shortened. And her chin deviated about 3 centimeters to the right. That was the fibrous ankylosis. So preoperatively, this was her virtual plan. So we did the maxilla first for her. These were the measurements. And we planned out, they gave us a cutting guide for the condylectomy. And SSO on the left side, genioplasty. And so this was her afterwards. Again, we did the condylectomy using the right fourth costochondral rib graft. This was how we laid the condyle in using the same transfacial risen approach and a pre-auricular approach. And this was her after. She still has like a centimeter deviated to the right side, but she was very happy. So this was our NYU algorithm for facial asymmetry. Anybody with condylar pathology, we would utilize the costochondral rib graft and the condylectomy. If the patient doesn't have any condylar pathology, then we would do mandible first with the inverted L osteotomy, AICBG, Lefort 1 osteotomy, sagittal split osteotomy, and genioplasty. So this type of rainbow reconstruction is very complex, and virtual surgical planning really has changed the game, and so this is our algorithm, and we're very happy that we can minimize surgical time in the OR and to give a better, accurate outcome. Thank you. Any questions?
Thank you very much.
Oh, no problem.
for the
Yeah.
presentation.
Yeah.
Quelqu'un a une question? Non? Non, j'ai une question. Je vais vous demander. When you do a surgery, to move forward the mandibular, you pass on the inside or never? Instead of,
It depends on the procedure. Repeat that
different.
question? Extra.
Oh, yeah. So
cut
for these
in-
cases,
in-
we had to do the transfacial just because the BSSO is good for facial asymmetry if you're just looking to get horizontal movement, but for vertical movement, there was too much that we wouldn't be able to accomplish, so that's why we did the inverted L osteotomy for that.
Okay.
Yeah.
Thank you.
No problem.
Thank you very much. Merci du coup à l'Université Noyau de nous avoir accueillis. Merci pour ces conférences de qualité.
Voilà, en tout cas, vous êtes les plus courageux, les mecs de parler ici. Voilà, on a terminé cette partie. Ce soir, on va se retrouver pour ceux qui peuvent au restaurant. Je crois que vous avez l'adresse pour le dernier repas entre nous. Et je voudrais remercier online l'université de NYU de nous avoir reçus. On peut les applaudir parce que ça a été une belle expérience. Je vous demande peut-être qu'on fasse une photo là tous ensemble. C'est une question, c'est une proposition de notre ami Karl. Et qu'on fasse pour ceux qui restent une photo tous ensemble. Voilà. Merci beaucoup à tous.
Oui, juste pour vous dire, n'oubliez pas de nous laisser vos casques, s'il vous plaît, c'est hyper important.